Thank you, Agnes. Before I start, I think I'd need to make a disclosure. I would like, when I'm presenting, I like to kiss the audience. Kiss standing for keeping it sweet and simple. So please, if you find me kissing you, please embrace it. So essentially, yesterday, we had a discussion on adolescents. Issues to do with adherence in adolescents were discussed yesterday. And for me, what we've been trying to do is to answer this age-old problem of adolescents, of adherence, specifically in the adolescent population. So the study we're going to discuss today is essentially adolescents and young adults, because the age group we looked at was up to 23 years of age. So just a recap of issues to do with adherence. There is debate over whether or not 95 or greater than 95% adherence is optimal. We've had discussions whereby some schools of thought are actually saying optimal adherence could be achieved at less than 95% adherence. So for us today, we'll work with 95. Allow me to work with greater than 95% adherence to achieve viral suppression. And then adherence assessment techniques in settings like ours are mostly based on self-report and pill counts. So you ask the patient, have you missed any doses in the past month? And the patient, more often than not, will tell you, no, I didn't miss any doses. And then the next option will be to do our pill counts. Okay, we expected the patient to come back with 4 tablets on their next visit. They came back with 4 tablets, and we assume, okay, adherence level was at 100%. Then there is this technology which involves medication event monitoring system, or simply put, your MEMS cap. As you can see on that image, that is a bottle of atazanavir, and sitting snugly on that bottle of atazanavir is your MEMS cap. So what it does essentially is it records each and every opening for those who haven't seen it. And when you download data from your MEMS cap, this is what it will look like. It will give you a calendar, and on each date, it will tell you the number of times the cap was opened. So for this particular patient, this was a participant in our study. This was the first participant who came back in our study. And as you can see, they're all zeros, except for the actual day when they came back for the MEMS download. So this was terrible, but exciting, because something is happening. We're really not sure what. And this participant, the download of the data from the MEMS cap was done in the afternoon. So essentially what this participant did was, at 16 past 12, they knew they were going to come to the clinic. They opened their bottle and did something. Then at 3:49, we opened the bottle for a pill count. So what I'll do is, to try and bring it home, I will deliver this in there's this leading case of this young gentleman called Brian. Brian is a 23-year-old male who got vertically infected with HIV. So he basically has lived with HIV all his life. And he has been on second line since the 29th of March in 2010. And has been receiving, and then was switched from lopinavir in March 2013. Brian is basically a happy lad. He's a great guy. Talk to him, he's he's a very, very outspoken young man. So this is Brian's adherence assessment as measured by the pill count. And as you can see, for both atazanavir and your dual formulation of tenofovir with lamivudine, essentially Brian is maintaining close to 100%, or quite recently has been maintaining close to 100% adherence to atazanavir and tenolam. So this is how the pill count data looks like. At Newlands Clinic, we have an EMR where it can automatically calculate for you your pill count data. So every time the patient comes back, you count the tablets, you key in the number of tablets they've come back with, and it calculates your adherence. So essentially, since December 2014, Brian has been maintaining more than 90% adherence, which essentially we're saying is quite good. Then you look at the lab data now. This is viral load and CD4 count data for Brian. As you can see, Brian has never suppressed. The viral load has never been undetectable, and immunologically is not doing so well. So essentially, we then did a comparison of Brian's pill count data and MEMS count. And this essentially was the day our eyes were opened. Essentially, as you can see, there are several zeros, which means the bottle was rarely opened, except on 4 occasions. So the MEMS showed that adherence was poor, and yet the pill count was almost always correct. They're always at 100% adherence. So the main objectives of the study were, when we went on to conduct the study, was first of all to ascertain the overall adherence of the adolescents, and then to compare our pill count with the MEMS cap technique. So essentially, it was a prospective study, and the participants were blinded to the effect of the cap, so they didn't know what the cap was doing. And these participants were on protease inhibitor, and this is an ongoing evaluation. The study is actually still ongoing. So what did we find out? From 26 of the participants, according to our MEMS data, we had 4 participants with adherence levels between 0 and 50%. But if you look at the pill count data, none of the participants had those adherence levels. And then when you look at greater than 95% adherence, when using our MEMS data, 9 of the participants had greater than 95. And with the pill count data, 22 of the participants had adherence levels greater than 95%, and 19 of them with 100% adherence. So you look at the median adherence recorded, it was 71% when we used the pill count data, and 100%, sorry, it was 71% when we were using the MEMS cap, and median adherence was 100% in the population when we were using the pill count. So essentially, we extracted from those participants those who had unsuppressed viral load data. And quite interestingly, participant number 11 always had a pill count of, which corresponded to 100% adherence. But when you looked at MEMS cap, they had 0% adherence. And the corresponding viral load, as you can see, was 93,000. So essentially, we found that the MEMS was a better predictor of your viral load data when compared to the pill count. So in conclusion, what we saw was that our pill counts overestimated adherence in our adolescent and young adult population, and median adherence was determined to be 71.5% now when we're using our MEMS versus the 100% we got when we used our pill count data. Essentially, so what is the message we're saying? We have got a pill dumping phenomenon in our population. Our patients don't want to take medicine. They understand the crux of the pill count. They know I'm supposed to bring back 4 tablets to the clinic, so they're going to throw away 26 tablets just to make you happy. So as clinicians, what we need to do, we need to be a step ahead of our patients when assessing adherence. And there are newer techniques to ascertain adherence. And for those of you who talk about the money, these costs add up. If you're talking of 10 pill dumpers, if you've got 10 pill dumpers in your clinic, that converts to a monthly cost of, they're throwing away $45 of atazanavir tinolone, converts to $5,400. That's an annual, and then in 5 years, that's $27,000. Multiplied by 150 OI art sites in Zimbabwe, that's $4 million we're using to treat toilets. So I think in conclusion, I'd like to acknowledge our funders. Thank you.